links contained to all of the prior lectures in case you guys would want to go back and see some of the prior stuff. So in this 5th week, we're going to be talking.
Do a little plug. Also, you guys follow the NJMS Orthopedics Instagram account. We'll have additional information on that. We're going to try to do additional stuff on the stories every couple of days, either via questions or just some additional information. And also, I think it's a good source to just follow our program and see, day-to-day stuff, activities that we do, certain labs and whatnot. So please follow, get those numbers up.
So the purpose of this lecture is to go over some introduction to total hip arthroplasty. We've tried to gear these lectures towards the M3s and M4s. We'll try and include some more complicated stuff for those who are starting their AIs, but we've tried to sort of bridge the gap so that it's educational for everybody. First, we'd like to start with a little bit of review from last week, which was on our total knee arthroplasty section. Joe gave this talk. I want you guys to think about this question while I try and figure out how to launch the poll. Relaunch. Can you guys see that?
Yep.
Cool. Great. People are doing great.
Also, for you guys that are new to us, if you guys have any questions at any time, feel free to just type it in the chat, and one of us will stop the lecture and go over it at that point or at the end.
Okay, so we had a little bit of a mix. Most people got this as the center of the femoral head down to the center of the talus. You may have seen the ASIS down to the medium malleolus. The time that you may see people using that reference is usually when, especially in pediatric clinics, when you're looking at limb length deformities or discrepancies. Sometimes you put a tape measure in. Those are the bony prominences that you palpate for putting a tape measure to measure the limb. But in terms of radiographically getting the perfect mechanical axis, it's from the center of weight bearing of the femoral head down to the center of force transfer at the talus. Okay. Next question. So question 2 here. How do I switch the poll to the next one? That's annoying. Jeremy, how do I advance the poll to the next question?
There should be an option that says question 2.
All right. It's like watching those little races where you're shooting your squirt gun at the state fair and watching the little thing run across the track, trying to watch these 2 bars race towards the end.
Uh-oh, there are 2 bars?
Yeah, we got to kind of even keeled here between varus and valgus. And that's okay. This is actually, it's confusing to wrap your head around until once it clicks, you'll never get it wrong again. When we talk about valgus at the knees, the visual appearance of it is that the 2 knees are close together. And when we talk about varus, the visual appearance is that there's a lot of space in between the 2 knees. So if you had a mechanical axis that's drawn from the center of the femoral head down to the center of the talus, and that line passed medial to the joint of the knee, that would mean that the knee was bent out laterally, and therefore there's a lot of space in between. So that would be a varus deformity. More technically speaking, the reason that's varus is because the distal segment of the joint, aka the tibia, is deviated towards the midline, and that's what makes it technically a varus deformity. Okay. Let's go to the next question. Oh, and so here's just a little schematic kind of helping you guys visualize that. In the image all the way on the right, the blue line represents the anatomic axis of the femur. And on the tibia, the anatomic and the mechanical axes overlie one another because the tibia is orthogonal to the floor, meaning perpendicular to the floor. But the mechanical axis of the femur is actually from the head down to the knee. And so it's actually off from the anatomic axis. And you can see that as we add deformity to this picture, if you had a valgus knee, can you guys see my cursor here?
Yep.
I think there's, how do I do that laser pointer, Jeremy?
Bottom left. There's some.
Oh, cool. All right. So if you had this valgus deformity here, then you can see that this line, the mechanical axis that goes from the hip all the way to the talus is actually lateral to the joint line. So that's a valgus deformity. Here, the mechanical axis goes from the head straight to the center of the talus, and that's medial to the knee joint. So that's a varus deformity. Okay. Question 3.
While you guys are thinking about this one, there's a question posted on the Instagram account that is similar to this. So you get 2 questions for the price of 1.
Dr. Rossman likes to grill our interns on identifying the 2 most common types of knee implants that are commonly used. And there's very specific implications, not only for if you're doing revision or what type of knee you do, but then also in the trauma setting if you're planning on fixing a fracture around a knee. So let's end this one. We'll talk about that. Okay, so 57% of people got that right. This is a posterior substituting knee. What that means is, if you remember back to Joe's talk, there is a form of knee where you retain the posterior cruciate ligament. And in that one, the femoral rollback on the tibia portion is caused by the posterior cruciate ligament. But in this form, which you can identify, this is called a posterior substituting. You can identify that by this large box on the lateral radiograph. There's actually a radiolucent post here and a cam mechanism. When the cam hits the post, it causes the femur to roll back. So that's why it's a substituting, because it substitutes for the PCL. And the implications of that when it comes to trauma, somebody have their
Who's that? Thompson or Ippolito?
It's Thompson.
background noise on.
Thompson, man.
I just
Jeff,
tried
can
to
you-
text him, but
Can you mute your microphone, Jeff? There's a lot of background noise coming through.
Sorry about that.
So the I suppose I can mute him if I ever figured out how to do that. So if you're dealing with a traumatic situation, if you ever find yourself having to treat a femur fracture that has a knee implant next to it, if you look on the lateral radiograph and you see this box, you know it's a posterior substituting. That's a closed section. So it's going to be, you're not going to be able to pass a retrograde femoral nail through there. The opposite of this would be the cruciate retaining type implant. Hopefully I have a radiograph here. There it is. So on the lateral, a cruciate retaining radiograph just has these pegs that are built for stabilizing the implant as the cement hardens and helping it fix. But those purely serve for fixation. They don't serve any kinematic function. The posterior cruciate ligament is still here and helps the femur roll back. So there's an open segment right here in this knee prosthesis that you could pass a nail up if you needed to. Okay, so question 4. Yeah, everybody's crushing it.
it's a tough question.
No, we're about there. Okay. So just about everybody got that one. This is, you guys are real smart. So this is, if you have a knee that's balanced in extension, if you imagine this schematic was in extension, the tibia would be articulating with the distal femur. And so anything you do to the tibia or anything you do to the distal femur would affect that extension gap. But now here we are in flexion. So anything you do to the tibia also affects flexion, but anything you do to the posterior femur, it only affects flexion. It does not affect extension at all. So we're balanced in extension, but we're tight in flexion. So we'd want to remove a little bit more here and leave the distal femur and leave the tibia alone. Okay, so it's just kind of redemonstrating that. And here you can see how those two come into play. How you have a gap, and you can see that this square box, we're always trying to make squares, but this square box incorporates the tibia both in extension and in flexion. So anytime you cut the tibia, you're affecting both gaps. All right, this is the most important question of the day.
Joe Ippolito was really excited about this one.
I
right
will,
out of my PowerPoints.
That's where I got it from. I told you he'd be.
so there are two types of people in the world. Those are those who put their toilet paper with it hanging over, or those who put it hanging under. And I will tell you that one of these is clearly wrong.
Yeah,
I expect
couldn't agree more.
100% here.
Couldn't agree more.
Do you already know what I'm answering?
All right, so we've got 7 people out there who are a little on the bizarre side. They're probably also left-handed, you know. So,
Can you show the
all right.
results?
Show me the poll.
Poll's not
I
there.
thought I did it. I thought I did it. There you go.
Oh my God.
16% are with me.
So 84% of people have figured out that it is easier to find the end of the toilet paper if it's over the front. But if you put it under the back, yeah, it's just all right. I can't even go into it.
What do you
All right.
Galloway, you're lucky I didn't ask you that when you were interviewing for a residency spot.
Oh, I would have flat out told you straight up. I know exactly where my loyalties lie. All right, so let's go to hips. So the objectives for this talk, we want you guys to be familiar with the terminology, the nomenclature that we use in total hip arthroplasty. We want you to be able to describe the pertinent anatomy and the structures that are at risk when we're performing these procedures. We want you to understand the basic mechanics of the hip, and then you should be able to create a foundation of the steps, and understanding that every single arthroplasty surgeon you ever work with or shadow, or even when you know, if you go into orthopedics and you start doing this, everyone has their own way, but they're all permutations of the same set of steps. So we want to kind of go through those. Then we'll go over a case which Dr. Rossman was kind enough to provide for us, and then we'll wrap it up. So just some really basic nomenclature. What do we talk about when you hear us shouting out all these names? So the basic anatomy of a hip implant, you have a cup, and you have a stem, which will be next. But the cup can be broken down into multiple parts. You have the acetabular shell, which is this part. It has a metal component, that's the shell that has the fixation portion that fixes to the bone, whether by on-growth or in-growth. Then there's a liner made of plastic, a polyethylene, that reduces the coefficient of friction and allows this thing to articulate. That's also called the liner. You call it plastic, you call it poly, you call it a liner. Sometimes it's made out of ceramic. That, I think that's pretty rare. I've honest to God never seen a ceramic liner total hip performed, but those are out there. Then you have the head. The head is this portion that sits on top of the stem, and it is the ball that forms that component of the ball and socket. This is typically going to be made out of a cobalt chrome or a stainless steel or a ceramic. Those are the most common ones that I've seen. Sometimes you can have a skirt on this, and we can talk a little later about the implications of that. And then you have your stem. And the stem has several parts that are important for us to talk about. The overall anatomy, we refer to this top part that's on an angle as the neck, just like the anatomic portion of the femoral neck. We have the body here, which has the roughened surface for bony on growth. That portion will not be there if this is a cemented type arthroplasty. We can talk about that a little bit. We have a trunnion, just ignore collar. I don't have a picture to show you what a collar is, but we can talk about it later. This is the trunnion right here. It's this, it looks like a very precisely machined and tooled portion at the top that's a perfect cylinder with a taper. Okay, so it's not, sorry, it's not a perfect cylinder, it's perfectly circular, but then it's a cone of a sort. And that allows the head to mate on it and fit securely. We talk about this trunnion all the time if you're doing revision and it's damaged. That has implications for what you would have to do with it. And then we talk about the stem and we talk about the offset. Offset refers to this distance D, which goes from the center of the femoral head to the main body of the stem, okay? And that's gonna be reproducing the offset of the proximal femur, okay? So we can change the length of the neck, we can change the length of the offset, we can change the angle of the neck, and we can change our body size. All of these are modifiable based on the manufacturer. And so it's important that you understand what you're working with. Just to show you the confusion that it generates, this is just one variation of one implant by one manufacturer. So just to look at how these different aspects we can change might affect it. If we went from a standard offset stem that looks like this gray body one to a high offset stem, the body would be the same, but you can see this copper color coming out to the side here. That's the modification of that stem. That's the high offset. So it lengthens in that dimension. Sorry, this is the standard offset is the gold compared to the high offset. And then if we change the angle, you can see on this gray one how it goes from a standard 133 to a 123, and all of that affects where the center of rotation would be. And so all of this comes into play when you're doing your templating and where you want the center of the head to be. Just to show you what it looks like on a radiograph, again, you have the cup, plastic, head, and stem, and you can see the shell. Sometimes we put screws in place. You can see the head and the stem, but sometimes depending upon your view, you may have opportunity to see the polyethylene liner, but you won't see it because it's radiolucent, meaning X-rays penetrate straight through it. Some other things you'll hear us shouting out in the operating room. We talk about using cement called polymethyl methacrylate. Different parts of the implants have on-growth or in-growth portions that allow for bony fixation. We call that a biologic fixation, meaning it doesn't have to be held with screws or it doesn't have to be held with cement. The bone grows directly to the implant. We use different osteotomes. The box osteotome is a critical portion. We use a canal finder sometimes. In some types of implants, we use reamers. We use a broach, which I'll show you pictures of, we'll talk about. We ream the acetabulum with various sizes. And then we move to our trials, which are just imitations of the implants we're going to use in order to determine if we're happy with it. So let's go back to the basics of arthroplasty and why we do it. It's done for pain. It's caused by arthritis, whether that's caused in the in the pathophysiology, if it's rheumatoid or osteoarthritis. There are characteristic signs that we look at. And if you guys remember from Joe's talk, there are 4 cardinal signs of osteoarthritis. So early on, as we begin to get loss of joint space right here, we will begin to have sloppy motion in the joint and the bone will react, forming osteophytes, trying to contain that motion in the joint. So that happens early on in conjunction with that joint space narrowing. After these two happen, you begin to get increased contact stresses and you'll get osteosclerosis. The rheumatologists call it eburnation or polishing of the bone. And the fourth is cyst. Wait, nope, that's not that cyst. Nope. Nope. There we go. We can get these huge cysts in the bone that are caused by microfractures, and then synovial fluid leaks into the bone and causes osteolysis. And then we have these enormous cysts that cause contact stress issues, and it only accelerates the problem. Okay, so osteoarthritis is an incurable disease. We have no way of reversing it. We have ways that we think can slow it, mostly lifestyle modifications, or we can just cut it out and throw it away. So the goals of total hip arthroplasty, The patient-related goals are to alleviate pain, restore mobility, and restore quality of life and independence. We do that through these technical goals of restoring anatomic relationships of structures, the offset and the length of the leg. We want to provide stability to the hip through correct positioning to prevent the hip from dislocating. And we want to, in addition to the hip itself being stable, we want the implants to be stable so that they won't loosen, so that they can grow in and be firmly fixed. And we always want to preserve the bone that's there. We don't want to go crazy. So how do we do that? We need a roadmap to get there. There are a variety of surgical approaches that have been described. For the sake of this lecture, we're only going to have time to talk about two. So I've picked the two that I've seen most commonly. The posterior approach, called the Moore and Southern approach, and the anterior, or the Smith-Peterson. I would say that the Watson-Jones and the, I have seen the modified Hardinge a good bit. I don't know if I've ever seen a true Watson-Jones used for arthroplasty, but we're only going to talk about posterior and anterior just for the sake of time. But the end result is they all lead to the same place. Okay. We want to establish an exposure, that we have a good exposure of the femoral neck. We want to be able to get the femoral neck out of the way. Then we want to prepare the acetabular component, the acetabular fossa, for receiving the component, and to prepare the proximal femur. So let's briefly talk through this approach. For a posterior, the anatomy that you need to be familiar with on the surface, you have the gluteus maximus coming in from the posterior, inserting onto the IT band and the fascia lata. From the front, you have the sartorius, which is going away from you and will never be in your field. And you have the tensor fascia lata. So we're gonna just reviewing some deep anatomy before I show you the approach. If you guys recall, once we get underneath the gluteus medius and the abductors and the gluteus maximus, we have the sciatic nerve. This is the most important structure that we're going to be protecting during this approach. We have our piriformis, and typically the sciatic nerve exits inferior to the piriformis. Sometimes you say anterior because we're looking from the back here, and it is anterior to that. And then we have our short external rotators and the quadratus. Okay. Once we get deeper, we can see the capsule is laying underneath the external rotators, and that leads us to the head. The important osteology you need to remember when you're doing this approach, you need to be familiar with the greater trochanter, where it's located and how the tendons insert. You need to recall the lesser trochanter is right down here at the takeoff of the inferior neck, and we often palpate this when we're determining where we're going to cut the neck. Okay. So this approach is going to be done in a lateral position. We typically make about a 15-centimeter incision starting from near the posterior superior iliac spine, curving over the posterior portion of the greater trochanter, and then down in line with the femoral shaft. After coming through the subcutaneous tissues, we cut the fascia of the fascia lata and down in line with the iliotibial tract, and we divide the gluteus maximus. Once you come through there, we find some bursal fat overlying the short external rotators and the tendon of the gluteus medius. Here's our trochanter. This is our landmark. We're going to have to take down these short external rotators from a posterior approach so that we can get into the hip and do the work that we need. So typically we'll place a stay suture or a tag suture into the piriformis so that we can recognize where it is at all points in time, and then we can repair it at the end of the case. We will then incise those tendons and reflect them posteriorly. And reflecting them posteriorly does two things. One, it shows us the capsule so we can do our dissection, but number two, and importantly, it protects our sciatic nerve. As we fold that envelope back over the sciatic nerve, it keeps the sciatic nerve out of the remainder of our field as we're doing the rest of our instrumentation. Okay, so we have them reflected back here, and now we can cut our capsule to see the femoral head. Okay. So that's the approach. If we come from the front, an anterior approach called a Smith-Peterson approach, the important anatomy you need to be aware of. Similarly, we have the sartorius coming down the front, the tensor fascia lata coming down the side. And then once we get a little deeper, we have to consider the abductor and the tendon of the rectus femoris, okay? Right in line with the rectus femoris is the ascending branch of the lateral femoral circumflex artery. This is a significant bleeding risk, and you have to identify it and tie it off or coagulate it before going further. The important osteology you need to remember: we need to be able to identify the greater trochanter. We need to be able to feel the lesser trochanter, which now we're coming from the front, so it's hidden around the back. And we need to be able to identify the superior acetabulum and where we might place retractors over here, okay? This is typically done in a supine position. We make an typically much smaller incision than this. We don't extend it up the iliac wing, typically from about the ASIS, extending down the line of the femur. We come in between the tensor fascia lata and the sartorius, and we have to be aware that right there where we're trying to make our dissection is the lateral femoral cutaneous nerve, and we have to protect that. After we come in between those two muscles, which, by the way, this is a true internervous plane. I should have discussed that with the posterior, but this is the muscles to the lateral half of this dissection are innervated by the superior gluteal nerve, and medial to this dissection are innervated by the femoral nerve. So you're going truly in between two nervous distributions. Once we get a little deeper down, we're going in between the gluteus medius and the rectus femoris, okay? So you can see here, this was that vessel I was telling you about in this illustration that's been tied off so that they could then dissect further. Here's the rectus femoris. Here is capsular fat lying right in front of the capsule in between the gluteus medius and the rectus. We move those apart. You would never see all of this bone here. This is this illustration is for a slightly different purpose, but you can see the neck here. And when you're doing these procedures from the front, you have to cut the neck and begin to work it out of the way because you're in a much tighter space. In reality, it's going to look more like that. You can't see much of anything because it's a very small incision. So if we talk about our technical goals, we want to position our cup or our acetabular portion in an appropriate position, both in terms of how it angulates in the coronal plane, meaning is it abducted too much, is it too vertical, or is it too horizontal? And we find that the sweet spot for that is around 40 to 43 degrees. Somewhere in the literature, you'll see from 30 to 50 degrees. But if you make it too vertical, meaning a line kind of like this, going straight up and down, then you can see that all of this surface over here would be exposed and your femoral head could pop out, or certainly might be putting too much pressure because it's not contained well enough. And if it's way too horizontal, like a line like this, then you will impinge as the patient is trying to range their hip. The greater trochanter will impinge upon that. Anaversion, I'm going to show you a nice illustration that tries to help understand anaversion. This was difficult for me to understand as I was coming through. The anaversion refers both to the acetabular side. There's an anaversion to the acetabulum, as well as an anaversion to the femur. And that just refers to both of these components. If you're staring at the patient from the front, both of these components are pointed towards you, okay? So for the acetabular component, where we want to put that is about the same position of the native acetabulum, which is about 10 degrees. If you don't tilt it forward enough, don't give it enough anaversion, then they'll dislocate out the back. And if you do it too much, then they'll impinge posteriorly with poor range of motion. Where do we want to position the acetabular cup in the other dimensions in terms of verticality or medial lateral dimension? So in the height, we want to position the inferior margin of the cup about at the level of the teardrop. The teardrop, if you look over here, is just this radiographic shadow that you can see on a normal hip. It looks like, well, it looks like a teardrop. You can kind of see it there. And in terms of medial lateral dimension, you typically want to think about placing the margin of the cup all the way towards the ilioischial line, which is here radiographically. It's the inner table of the ilium, but you don't always have to push it all the way in. You can save some bone and maybe just get close and save for later if this patient's young and may need a revision at some point in their life. But The main point is you need to go deep enough to get good bleeding bone. You need to go, and if you do medialize, that can improve your mechanical advantage. I'll show you that at the end of the talk. But if we go too far, it makes our job later a lot harder. Okay. So what about the femoral component? What are our technical goals? Where do we want to put it? Okay, so our goals of placement are to restore the medial offset. The medial offset refers to the distance from the center of the femoral head to the trochanter, which is where your abductor muscles are inserting. So you can imagine that if this trochanter was moved inward towards the midline, then these muscles would lose their tension. Okay, so you want to restore that offset so then muscles have tension. You want to restore the leg length. In other words, how high, where you position this implant within the femur can affect that leg length. And you want to restore the femoral anteversion. You recall we said 10 degrees was the correct anteversion of the acetabulum. We want to come about 35 degrees for the femoral component. I'm sorry, about 20 degrees. So that our combined anteversion is about 30 degrees. And when you're assessing your offset, you can look from the center of the femoral head to the trochanter, or a shortcut is to just look from the ischium to the lesser trochanter, and does it match the other side? Then we've restored our offset. Okay. All of this we should be thinking about before we ever get in the operating room. And it used to be that we would have these translucent pieces of paper with tracings on them that we would put on the x-rays. Now Dr. Rossman has really nice software that he's taught us how to template on the electronic x-rays, but it's the same thing. You're choosing where you want your implant to be, where is that going to put your center, and all of these thoughts happen before you get in the operating room. So just to help better illustrate anteversion, I took a picture of a couple of bony pelvises on the floor. And if you're looking straight on the pelvis, you can see it almost looks like you're looking right down the acetabulum, but it kind of looks like it's tilted towards you a little bit. Okay. And if we look from the bottom, you can clearly see how it's tilted in an abducted fashion. It's not straight up and down, and it's not straight horizontal. It's abducted. But if I put a reference here for your, oh, my laser pointer broke. Okay, for your eyesight, and I look with the camera straight down that vertical board, you can see how there's a lot of this acetabulum that's peeking out at us because of that anteversion is actually pointed towards us partially. And then if we look at the femur, it would be easy to think that the femoral neck is just in line with the femoral condyles. But if we look down the femur, you can see that if I draw a line across the posterior condyles of the distal femur and a line down the neck of the femur, you can see that those are not in line with one another. And it's actually about 10 to 15 degrees of anteversion. I duplicated a slide for some reason. Don't know why. Oh, this was to show you guys skirts. So these are just trial components, but you can have on these heads, these skirts, which these allow us to, in the operating room, make some final adjustments. If we think our limb length is not long enough, or we think we don't have enough offset, we can put a head that has a boost on it, basically. The depth of the head is not as deep, so it makes it sit more proud, and it gives us more leg length, and it gives us more offset. The downside of this skirt is it can reduce range of motion a little bit. Okay. So let's talk a little bit about the technical steps. After we've done our approach, however we got there, we typically start with the acetabulum after we've cut the femoral neck out of the way. And we use these reamers that look about kind of tantamount to a cheese grater on a wheel. And you remove bone from in the acetabulum. You have to get through all of the cartilage that remains there and then get down to good, healthy bleeding bone. Then we have these, which are trials, which have these ridges on it that can bite into the bone, and we can put them in there and see if we're happy with how it fits. Then our final implant, modern implants typically are in growth or on growth. They have a roughened surface. And so that's what this looks like. And we usually put that in with an angular stable device. It's screwed into the cup so that as we're manipulating it and putting it in, we can change the angulation of that cup right as we're getting ready to mallet it in place. there are a variety of tools that you can use to help you to put it in the correct version and abduction. This is one that's provided by one of the vendors that you can align these two prongs with the body and help you determine how relatively anteverted you're placing your cup. Okay, not everybody uses those, but you may see surgeons use those. And then if we're either not happy with this stability, or we just are more comfortable by having more stability, we can put screws in if we need them. And typically we try and put screws into what we call the safe zone. The reason being that if we go inferior and anterior, or inferior and posterior, there's large blood vessels that if we plunged our drill bit, we could cause some lethal bleeding. But typically if we're shooting our screws, if you see, here's the obturator foramen, here's the iliac crest, so this is up. If we're shooting up and back, we're pretty safe. Okay, so that's the typical placement of the first screw, and then you get more creative as the case difficulty increases. Okay, so after we have our cup seated, then we put our liner in, and our liner, we have an impactor that we fit the liner into the cup, and then we mount it in place, and it usually clicks and locks in place. Then we turn our attention to the femur. This is that box osteotome that I told you guys about. This is a very important step because depending on if the patient has a lot of arthritis and overgrowth of the trochanter, sometimes you might not be able to get the correct alignment to put your implant right down the shaft. So you use this osteotome to remove some bone laterally to give you a better shot down the canal. Okay, so this is called a canal finder. After we've removed that bone, we then use this by hand to kind of feel and make sure we're going right down the center. And then this is a broach. I'll show you another picture. But the broach is basically a rasp in the shape of the implant that we're going to use. And this rasp removes bone in the appropriate shape. And when we're using this, we are determining what our anteversion is going to be. So typically, the surgeons you'll be working with and you'll be learning from will be typically pointing this down towards the apex here, because this was the native anteversion of the femur. So we're just trying to recreate the anatomy. In very complex cases, you can deviate from that, but that's beyond the scope of this talk. So from the front, this is what it looks like. Again, just removing bone in the shape of the implant that we're going to use. After we've done that, we'll remove the inserter and we put on our neck extension so that we can do our trials. And we would put a false head on so that then we could reduce that into our acetabulum and test if we're happy with what we've done. Is it stable? Does it feel right? Do we have good range of motion? And if we like it, then we can buy it and we put our final implant in. We have an inserter, we get to mallet it. It's a lot of fun. You have to be very careful when you're doing this part, because if you're hit too hard or if the patient has weaker bone, it is possible that you could break a femur during this step. So this is a very critical step. Then we insert our final head onto that implant, 7 taps per Dr. Rossman for Mickey Mantle. Then we reduce our hip and we're done, okay?
That'll probably be different geographically in different parts of the country.
That's right, yeah. The outcomes of the total hip arthroplasty are directly related to your baseball pro of choice. So let's go through a case. Here we have a 70-year-old male, with a history of prostate cancer. Only reason to put that in the history is just because you guys can see it. So, but that doesn't come into play in this case. He had a left hip that was done by another surgeon. So this makes our job a little more difficult in some ways, that we don't know what his normal was, but in some ways it makes it easier in that we know what he's got. And so when we're doing this side, we want to just match it. We want to match his limb lengths, and we want to give him a stable hip that's pain-free, and he's able to return to his activities of daily living. Okay, so here are our images. You can see he has osteophytes, he has joint space narrowing, he even has a little cyst in the femoral head here. So he's got some pretty bad arthritis. Just so you guys know what this is a marker film. This is a steel ball that the radiology technician places in the field, and it's exactly 1 inch in diameter, or 25.4 millimeters. And this is for when you're using electronic software to template, you can tell the computer exactly how big this is. And then once the computer knows how big that is, you can take all sorts of precise measurements. Okay, so we went through all of those steps, and here's our final implant. If I show you the comparison, you can see a lot of interesting things here. So from our other surgeon, you can see that this just looks like a perfect hemisphere. We can't really see much of anything. But if you look on this side, you can see that that hemisphere is actually tilted towards us. It looks like an open mouth. I wish you, can you see my hand? If it's sideways here, it's turned, canted towards us so that it almost looks like an ellipse now. So that's the anaversion. So we did a pretty good job of putting some anaversion in there. Okay. Again, this screw is inserted superior and posterior. We've restored our offset pretty good. If anything, I think we gave the patient a little bit more offset on this side. So this hip is probably going to feel really nice and stable for that patient with low chance of dislocation. Okay. In terms of the limb length, here's our trochanter related to the ischium. And on this side, about the same. Looks like we did a pretty good job. We may have made the patient a millimeter or two longer. Okay. So here's a little bit of bonus. This is just fun to talk about the hip mechanics. If you think about the pelvis and the center of gravity pulling down on the center of the pelvis, that's going to want, and imagine in your mind, just isolate, get rid of 1/2 of the pelvis. So we're going to look at the right femur. You can see how this pelvis would want to rotate around that femur. And to prevent the pelvis from falling in space, your abductor muscles attach here and pull the pelvis back down. So it can be thought of like a balance. On one side is gravity pulling the pelvis down around the hip joint. And on the other side, the hip abductors are pulling the pelvis the other direction. You can see that as we change the center of rotation or change the location of the hip joint relative to the center of gravity and relative to the location of the abductor insertions, that this becomes a mechanically disadvantageous position. If we move the hip center closer to the abductors, then the center of gravity has a mechanical advantage, and that only amplifies the more you do it. So if we look on this x-ray and we compare the prior surgeon to how we did, if we look here and look at the center of rotation, okay, we look at the center of the femoral head and we relate that to the center of gravity of this patient. Here is the ilioischial line, meaning the inner table, and there's a lot of space remaining here that this cup could have been placed deeper, okay? So if we look at this as a seesaw with the center of rotation being the fulcrum, then we have length A, which is the distance from the tip of the trochanter to the center of rotation, and length B from the center of gravity to the center of rotation. If we translate that over to our side, the overall distance from center of gravity to center of trochanter is the same. Okay, we restored our offset. The femur relative to the pelvis is in the correct place. But what we did was we moved the center of rotation. We moved it in a little bit. So the A became longer relative to this A, and B became shorter relative to this B. So that means that the hip abductor muscles have a mechanical advantage, and it actually makes it easier for the patient to walk. It reduces the stress on the joint. But we did not change the distance from the ilium. The distance from the pelvis to the abductors did not change to the trochanter. All we did was we moved the center inwards. And that's where I want to end it.
I have a question just on that, Joe. Say you have a patient that you're treating non-operatively with hip arthritis. My grandma, that's 89,
yeah.
She just got a cane. What are you telling your patients? Which side should she use the cane on?
Yeah, I completely forgot that that's what I wanted to go with after this slide. So thanks for asking that. So it's very counterintuitive. It's very interesting. If you have a patient who has severe pain in their hip, they have this real bad arthritis here, but they're maybe not ready for another hip. Then typically in our heads, we like to think about patients holding a support on the side of their injury. But with the hip, it's actually the opposite. If you tell the patient to hold the cane in their left hand, then if we go back to that illustration and think about the lever arms that are seeing here, then by putting a cane in the left hand, what you're essentially doing is you are lessening the load on B, or another way of thinking about it is you are adding load to A. You're giving more strength to A, okay? And what that does is it decreases the center of gravity pull on this lever, and therefore decreases how hard these muscles, the abductors, have to pull to balance the pelvis. And by doing that, it dramatically decreases the amount of force that's seen at this hip, okay? So just by putting a cane in the left hand and having the patient put only 5 pounds through their hand, they can reduce the forces seen at their hip by 30, 40, 50 pounds easily. And another thing that you can do if your patient has a handbag that they carry, you can tell them to hold their handbag on the side of the bad hip, because that adds weight, it adds force to the shorter working distance, which therefore, again, decreases the amount of work that the abductors have to do to balance the pelvis. And by decreasing the work that the abductor muscles have to do, you decrease the joint reactive force that's seen there. So it actually...
So Joe, we have a question in the chat as well too. Yazan asked if it would be possible to additionally just change the angle of the neck rather than, or in order just to change the moment at the joint, rather than talking about some offset and other things.
Yeah, so you can do that. If you went from a 133 degree neck, it's kind of interesting. We can look at these two implants here. If you look at this implant, this one seems to be put in a little bit of valgus, meaning that if you look at the angle from the shaft of the femur to the neck of this implant, that is maybe, I don't know, let's make it up. Let's say it's 135 degrees. And then if you look at the angle from the shaft of this femur to the shaft of this neck, maybe that's 130 degrees, okay? So you can see the difference by decreasing the neck angle. You actually make the horizontal limb, the x-axis of this is the hypotenuse. So you make the x-axis longer and you decrease the y-axis. So by changing the neck angle, we can modulate whether we're increasing neck length or whether we are, limb length, or whether we are increasing offset. The downside to doing that is that you're changing the forces that are seen. So if a patient has a normal neck angle of about 135 degrees, it's typically best to use the same angle, because if you put an implant with more varus, then, and this is getting pretty advanced, you're going to have more shear forces that are seen across this neck. So it's not without unintended consequences. You may get away with it just fine, and oftentimes we do use a varus neck angle when needed, but it's not as simple as it only changes one thing. It also changes the forces that are being seen on the implant.
Galloway, could you go to that picture you had before that had the 3 different types of neck on the taper lock, you know, the actual clinical picture? Because I think, you know, I understand that. No, keep on going.
Yeah, no, it
Okay.
lags here because these
you.
are large file sizes.
Because I understand the topic, but even your explanation was good, but it's still confusing.
It was probably not good then.
No, it's all right. It's a complicated thing to talk about without physically showing it. Boom, there it is.
So let's see, we'll start with gold. This is a standard offset, standard angle. This is very, very routine. Each manufacturer may be a degree or two off from this, but let's say around 131, 132, 133 is pretty normal, and a standard offset. And we put all of these implants in the exact same place. So the body fits in the exact same portion of the femur. If we look at where that would position this trunnion, which is that top portion of the neck of the stem implant, then when you mount the head on that trunnion, the center of rotation would be right here. Okay. Now, if we change that to a lower neck angle or a varus neck angle from 133 down to 123, you can see that the majority of what happened was you swung that down. And as you move the center of rotation of the hip down, well, it's not just going to be floating in space. The limb is then going to suck back up into the acetabulum. So this will effectively shorten the limb relative to the 133 degrees. If we don't want to change our angle, we can use this high offset. The bronze one here is in the same angle as the standard, but they just built in more metal. It's just longer. And so this is a really nice option because we don't change our angulation. We don't change our forces that are seen across the implant. And all we're doing is we're increasing the offset. However, by increasing offset, this is increasing in line with the neck implant, the neck of the implant, okay? So remember, that's the hypotenuse. So when you increase the offset, and there's a caveat to this, you will increase the horizontal offset, meaning the tension on the abductor muscles, but you will also increase the leg length. Now, I believe the manufacturer that Dr. Rossman uses, when they do a high offset, they literally retooled the whole thing so that this neck portion is actually mounted more medial, so that the height never changes, but the offset just drifts over. So there are a lot of really cool things that require that you have a deep understanding of the implants that you're using. But, you know, the purpose of this talk is just for you guys to kind of have an understanding of what we're talking about. And that way, when you're reading, it kind of takes you to the next level.
I have another question. Joe, in your example, you used a case that already had a contralateral hip arthroplasty done. When you're operating on a patient the first time and you see that they have arthritis on the other side, are there any things that you're thinking about doing that will be different in the case than what you explained, how you're just trying to match the other side?
Yeah. So if you guys remember the goals of our arthroplasty in the beginning, the patient-related goals, we want to take away the patient's pain and restore their mobility. But the very important technical goals, we want to, if we can, restore offset and leg length. We want to put anatomic structures where they belong. But I would argue that this is possibly the most important of these goals. I mean, it's hard to put one of them over the other, but you want to put the patient you want to set up the patient to have a stable hip that they're not going to dislocate. And so it's very common, I would say the norm, that when you do a total hip, you make the leg just a little bit longer, because that puts more tension on the muscles, more tension on the soft tissues, and it makes the hip more stable. Okay. You might be really hesitant to add much length to the hip, and you might be trying to favor the anatomic relationships and making the pelvis level if their other hip is completely normal. And then you don't want to make their pelvis all cattywampus by making one leg 2 centimeters longer than the other. But if they have a bad hip on the other side, you know you're going to be coming back in, you know, maybe a year and a half to do the other side. If the one you're operating on now needs a little extra length to give it stability, you can do that knowing that you're going to come back later and probably make the other leg just a little bit longer.
So we got one more question just coming from the chat too. Somewhat similar to these goals that we're talking about with total hip, but just can you talk a little bit about post-op recovery, what to expect in kind of the immediate post-op period versus kind of long-term, what these patients are doing with their total hips?
So going back to these approaches, this is where the post-op protocol may deviate a little bit, but by and large, all patients after total hip now in modern standards are weight bearing as putting full weight on the limb immediately after surgery, day one, or even day zero, same day as surgery, and walking on it. And in a healthy patient, especially one with good muscular tone who's in good fit and shape, they can often go home the next day after surgery. And typically they're not going to be driving or any activities like that until they're well off of narcotic pain medications. And I would be interested to know what Dr. Rossman's protocol for this is, but for lower extremity fractures, there are some studies that show that when patients drive, their ability to stop the car in a standard time doesn't return to normal until about 9 weeks after a fracture. So you know, different patients are going to get back to regular activities at different time frames, but they're not going to walk out of the hospital and start driving immediately. It's going to be a couple of weeks typically. And
But at the same time, most patients are going home.
most patients are going home. And
primary total joints are going home, not typically going to rehab.
Right. And then the biggest thing is that many patients who I would say a posterior approach is still a very, very commonly approach to use. I don't know if it's the most common at this point. I don't know the statistics on it. But it is a very commonly used approach. And when you go through the back, if you guys recall, when we do our capsulotomy, we have to take down these external rotators, and then we take down the capsule in the back. And 90% of hip dislocations happen out the back. That's just anatomically where a patient puts their leg that puts the limb at risk to dislocate. It usually goes out the back. So we've already damaged the tissues back here. We've decreased the tension of the capsule of the external rotators. So these patients are at an increased risk for a dislocation. Now, we can decrease that risk in a variety of ways, giving them a firm closure, repairing the short external rotators, and we can reduce their risk of dislocation to essentially the same as the other approaches. But we're always cognizant of that. And so we put these patients on what we call posterior hip precautions. Posterior hip precautions are just, we instruct the patient, we teach them, we show them, and we have the therapist show them and teach them the positions that you never want to put your leg in, because those positions are the ones that would dislocate the hip. The positions that put the hip at risk for dislocating are hip flexion, especially flexion past 90 degrees, crossbody adduction or bringing the knee toward the midline, and internal rotation. All of those, and especially all three combined, will push the hip out the back. So the patient is never supposed to do those movements in the postoperative period. And I'm trying to think if I know any time period. Dr. Rossman, do you have a time period in your head when you're, sort of cognizant or like concerned for these patients? Like 1 year, are you less concerned about them? It's all scarred in and
typically at about 6 weeks.
6 weeks.
6 weeks once the tissues have healed. There's surgeons and centers around the country that do a posterior approach and then don't do any, abduction pillow whatsoever. That's ballsy, but these people have names and fathers of modern hip replacement. So I'm not one of those people. So I'm going to stick with that pillow for now.
Yeah. So when patients go to sleep, we typically put a triangular shaped pillow between their legs and strap their legs to the pillow, because you can instruct a patient all you want while they're awake, and maybe if they're intelligent or if they feel like following your advice, they won't do those things. But nobody can control what their body does when they sleep. So we usually just kind of strap them down.
Hey, Jeff, maybe you can answer this question. Joe talked a lot about stability and different ways we can adjust stability. How are we checking that intraoperatively? What are we doing with the patient's leg?
Yeah, of course. So once we kind of get our implants, at least our trial implants in place, Joe spent a good amount of time showing pictures of what we can put in terms of a trial liner or even a trial neck and head system. Again, we have templated this using the computer programming ahead of time, so we have an idea of what we want to use in terms of size-wise for the implant to be stable. But once we have initially our acetabular cup in place, either with a trial liner or the final definitive liner, as well as the broach down the femoral shaft, we can use a series of modular trial pieces that fit directly into the broach, both a neck and a head piece, that both come in the sizes that are available for our final prosthesis. Again, it's important to remember that the modularity of the trial in terms of the broach and neck are both two pieces when you're trying it out in the OR, but when you get your final prosthesis, that is one prosthesis or one single piece of metal that, again, limits motion throughout the implant itself. But once we have our pieces in place, we can reduce the hip. Initially, you'll get an idea on whether the hip itself will be stable based on how easily the hip is reduced with those components in place. And at that point, we check the stability of the joint by bringing the hip through range of motion. We'll check the patient in the position of sleep, which is adduction, internal rotation, as well as bringing the leg through forward flexion. Additionally, checking to see essentially how much external rotation is required until the hip begins to sublux and may even subsequently dislocate, giving us an idea on whether the hip itself is stable. Ultimately, we will also check leg length by comparing it to the contralateral leg, by measuring both the, essentially you can feel almost the length of the femur by comparing the patella bilaterally, or you can judge the overall limb length by palpating the medial malleolus on both sides. Again, as we talked about, if you have a already shortened contralateral leg, something that you ultimately will replace down the line, you're not looking for a perfect match at this point. Something that you can ultimately plan to go a little long on the first hip replacement and come back on the second one to even the limbs out. But essentially, it's taking the hip through the range of motion that you kind of are the provocative maneuvers for the hip to see if it is dislocating, particularly keeping in mind that this is without any of the soft tissues in the posterior hip in place. So if the hip is stable through these maneuvers with the patient completely relaxed, it will likely be stable postoperatively with a soft tissue repaired, and again, the patient awake.
Sounds good. Then we have some other questions from the chat. What type of exercises should they do or should they stay away from in the post-operative period?
Probably just dance to YMCA most of the time. So the exercises to avoid would be any exercises that put you in those dislocating prone positions, meaning cross-body adduction, hip flexion past 90 degrees, or internal rotation. They need to avoid those types of exercises. They're not really trying to do anything in terms of really strengthening any in the early postoperative period. But once everything is scarred back in and healed, then patients can go back to a very large variety of things. It's very common for we typically allow patients to cycle. We allow patients to swim, even play maybe doubles tennis. We typically don't like patients to do anything that are impact related sports, just because of the risk that puts a patient for dislocation. Some patients do ski after both hip or knee arthroplasty. Not advisable. If you're a novice, should probably be an advanced skier going into it, and then be able to control it going out of it. One specific thing we didn't get to talk about it owing to time, but in these two procedures, the approaches for a Watson-Jones procedure or a modified Hardinge, both of these involve taking a part of bone off of the trochanter and partially injuring to some degree There's a lot of nuances in between these, but in some manner of speaking, the abductor muscles are injured. And so typically for these, you're going to have a patient have no, they're not going to be allowed to do any active abduction in the postoperative period until this is healed. Was that sort of to the tune of the question? What exercises? I think he was probably asking more about like sports and things like that. Cycling is great. Also, running, not great because it's an impact related exercise, and especially with the older plastic or polyethylene, the biggest issue that the most common reason for revision hip and knee arthroplasty is osteolysis, which is outside the scope of either of the two talks that we went into. But basically, you get tiny particles of plastic that activate a inflammatory cycle through macrophages, and bone basically gets eaten away, that then causes instability, and then you need a second surgery. So anything that increases the loading of that plastic, especially in a jarring loading, would accelerate that process. So we typically try to avoid patients running. The plastic has gotten a lot better over the years, but I don't know. I don't know if anybody's saying, yeah, sure, go for it, go run. In general, if you have a patient who's at the point in time where they're getting an arthroplasty, it's probably few and far between where you're having that conversation, telling them to slow down and stop running.
One other question. Do you use cemented versus uncemented fixation in these?
Yeah, that's an excellent question.
When do you use?
I debated if I wanted to go into that for this talk, but it was already getting long enough. If you go back into the history of arthroplasty, especially looking at hips, when Sir John Charnley was doing these, he was cementing initially everything, the acetabular component and the femoral component. Early on in the process, surgeons got away from cementing the acetabular component. It's been shown that that does very, very well, much better. Like there is a significant difference and improvement by doing a non-cemented implant for the acetabulum and allowing bony ingrowth. With correct cementation techniques, I don't know if anyone has definitively proven that there's an improvement with the femoral component, whether it's cemented or not, but there are certain times that you might want to lean one way or the other. In a very young patient who has great bone, doing a non-cemented technique allows for the bone to grow into the implant. When the patient walks on it, forces will be transferred from the implant to the bone. That helps the bone remain strong and decreases osteopenia and helps preserve bone throughout the patient's life. Contradictory if you had an older patient who already has very poor bone stock, or there are classifications we use for the shape of the femur, but if basically the opening of the canal of the femur looks like a giant stovepipe, they have really thin cortices. And you remember I showed you that picture when we're malleting in a non-cemented implant, you can fracture the femur. If you are really concerned about fracturing the femur, you might consider using a cemented implant because it's far less traumatic in that manner. What else? With a cemented implant, though, there are some little tricky aspects to it. Whereas with a press fit or a non-cemented implant, if you use those broaches, your rasps correctly, and you're putting them the correct version and the correct placement, then when you put your implant in, it's just going to follow the path. When you're using a cemented implant, it's kind of swimming in this 2 to 3 millimeter pool of cement, and you can kind of put the implant wherever you want. So you have to be very careful while that cement is hardening. You've got a limited time frame, and it's a fuse that's going to run out, and eventually the implant's going to be where it is. So you have to be very careful when you're putting it in, make sure you're putting it in the correct position. But under the correct indications, a cemented implant can have great outcomes. I think Dr. Charnley's outcomes, he had 20, 22, 25-year outcomes with his hips, and they were cemented. So
even 30-year
30,
data,
yeah.
longer outcomes.
Yeah.
But that was a good explanation, Joe. In general, in the United States, the gold standard hip replacement is going to be an uncemented fixation across the board, with either a metal head or a ceramic head and a polyethylene or plastic insert. More and more at the Hip and Knee Society meetings, more and more people across the country are starting to use ceramic heads across the board due to some newer things coming out, something called trunnionisis, where there's metal debris. But in general, everybody should get a uncemented implant as the gold standard is what's being done. Doesn't mean that longevity is any better than the previously used cemented implants. There's no better, but that's just what's done in this country nowadays. And like Dr. Galloway said, there are reasons why you may want to use a cemented implant in a hip replacement. One of the reasons, one case in which I did it was a 50-year-old HIV patient who had very, very poor bone quality and worried about fracturing her femur. So we used cemented implants on both of her hips as just an example. Tumor may be another reason. If somebody has a tumor, whether it's for primary or secondary metastasis, if their bone is not properly bleeding and is not healthy, then they do not have the biologic capability to ingrow or ongrow to their components. And so putting a uncemented implant is asking for problems down the line. And for a patient like that, you may want to cement it in. So it's not a cut and dry question or answer, but in general, hopefully that answered it for you.
Any last questions?
All right, guys. Really, really appreciate you guys taking an hour out of your evening to come and join us for this lecture. Hope that these are helping, supplement education as we're in a kind of different time right now. And we'll try and keep them going as long as we can.
If you're not on the email thread, you can email Joe Ippolito. I shared his email address. Also feel free to reach out on the Instagram account and we can get you plugged in that way as well.
And you guys can feel free to share it if you know any other students who are interested or anything like that. If we reach a point where we're at a sort of maximum capacity, we've discussed if we may expand our account. So it's okay if you guys want to share it, that's fine. We'll welcome as many students as want to join us.
It's the same link every week, and it'll be next time at Wednesday, 7 p.m. Eastern time.
Oh yeah, that's a good point. You can use the old link even from the first email. It'll bring you into the same meeting.